Hello and good evening. It's 8 p.m. UK time, so it is time for our second live event tonight, and we have another IVF webinar. And I am here tonight with Dr. Mara. Hi, Dr. Mara. How are you today?
Hello, everyone. I'm doing great. Looking forward to it.
Fantastic. Thank you so much for letting me know that you can hear me. And please let us know that you can hear us loud and clear so we can make sure that all is okay. And well, tonight we have another interesting topic to discuss. And as always, we will start off with the presentation. And after that, we will go for your questions. And just let me remind everyone that the Stronger Together events, all of those events are brought to you thanks to our ambassadors and partners, and you can see them all right here on the screen. There are some new faces on that join our initiative as well. So again, as always, I would like to thank them for their assistance and their support as well. And tonight, as I've already mentioned, we do have another topic, very interesting topic to discuss. And our guest tonight is Dr. Mara Simopoulou. I hope that I said it correctly.
That was fine, Caroline. That was fine.
Thank you.
Good accent.
Thank you so much. And she's actually associate professor at National and Capodistria, University of Athens, and she's going to present a topic on assisted reproductive, some novel approaches. So I am really looking forward to this topic. It's something that I know all the patients are asking about. So I really hope you will have lots of questions, and I'm sure Dr. Mara will be happy to answer them for you. So that is it from me at this point. Okay, remember to type all of your questions in the chat section, so we will be showing those questions on the screen after the presentation, and Dr. Mara will simply answer them for you. Okay, thank you so much. Dr. Mara, are you ready to begin?
Absolutely. Thank you for a kind introduction, Caroline. And I'd like to welcome you all to this webinar from Athens, Greece. I'm Dr. Simopoulou. I'm a clinical embryologist and a researcher, and I'm passionate about the pre-implantation embryo. So when I was asked to select a topic to present today, I decided to discuss ovarian insufficiency simply because we get, I was saying to Caroline just before, we get so many women actually calling in, inquiring on these novel approaches and what they are and so on and so forth. And basically, the main question seems to be, is there anything else to try before we try oocyte donation? So I thought it would be a good idea to see what are the so-called novel approaches. So why are we here today? We're here today because fertility is a reality, and it's an everyday life reality. We have 1 out of 8 couples worldwide facing infertility issues, and a considerable percentage of these couples are actually IVF because of ovarian insufficiency, and that should be addressed. So before we start, just a couple of basics. We're going to be discussing ovarian insufficiency. So what about the ovaries? What are the ovaries in a nutshell? So the ovaries are the primary female reproductive organs, and they have an endocrine function and they have an exocrine function. So they have 2 jobs. One of them is to secrete hormones, the female sex steroids such as estrogen. And basically within the ovaries, we have the follicles situated, and within the follicles, we have the oocyte. So I'd like for you to think of the ovaries as the house for the oocytes. So basically what the ovaries should be doing is they should be supporting oocyte development, and they should be making sure that there is the release of a mature oocyte for every menstrual cycle. So ovarian insufficiency is a pretty fancy term, and basically it is what it's describing is a wide range of pathophysiological conditions, and I'm going to get to that in a moment and focus on that, because it's not just pathological conditions that lead to ovarian insufficiency. There could be physiological processes involved there as well. So these processes actually lead to compromise of ovarian function, and this is what is ovarian insufficiency. But how do we get there? So this is a highly heterogeneous population. It could be maternal age. Aging is one of the physiological processes that leads to ovarian insufficiency, leading us to perimenopause and menopause. And I will be discussing these categories of patients a little further down the line. Pathologies and surgeries, prior surgeries of the reproductive system, infections of the reproductive systems, autoimmune diseases, or mutations in genes that are implicated in the regulation of ovarian function are implicated, such as chromosomal and developmental abnormalities, or there are women that have been diagnosed with a malignancy and they are going to be subjected to gonadotoxic treatments, and such as chemotherapy or radiotherapy, and that is going to definitely lead to ovarian insufficiency. But we also have some data on ethnicity and how that affects ovarian insufficiency. And we know, for example, that Chinese, Latin, and African women are probably at higher risk of for poor ovarian reserve. And lifestyle, of course, as a lesser factor, but still, it's still there. And so, how do we recognize these patients? Who are these patients in the IVF lab, in the assisted conception unit? What is certain is that ovarian insufficiency is really challenging to treat. And in fact, I would like to change this word, not treat, but to manage. Simply because there's no consensus, really. There's no gold standard. There's no just one way of doing this, and no one has ever agreed on something very particular to say this is the way to do it, and everyone should follow it. So there's no consensus, and pretty much it's all side donation. And what we know about these patients at the assisted conception unit, we know that these are patients that produce oocytes of compromised quality. In other words, they don't really do very well in the IVF laboratory. They don't have a high fertilization rate, and they don't produce embryos of high quality. So that is an issue. Most of these patients may be unable to ovulate normally, and they're not responding very well to ovarian stimulation protocols. So these are some of the characteristics for these patients. But I'd like for you to think of ovarian insufficiency in two levels. So we have the milder form, if you like, where we have oocytes are being produced. So we have oocytes, but they're being produced in low numbers. And in most of these cases, they're also of low quality. So in this category, we have the patients of poor ovarian response, the so-called poor responders that I'm going to get to in a moment. And also with respect to the physiological processes leading to ovarian insufficiency for this group of women, we also have the perimenopausal women. And then moving further to a more harder reality, we have level 2, where there's no folliculogenesis and there's no oocyte production. So this is the hard, cold reality of ovarian insufficiency right there, with premature ovarian insufficient patients and menopausal patients. So let's just take that one category at a time, and let us start with the poor ovarian response patients, the poor responders. And who are the poor responders? So there's an ongoing heated debate in the scientific community with respect to how to categorize properly the poor responders. And thank to God, we're relying on criteria. So we have the 2011 Bologna criteria by Ashra, and according to that, there should be 2 out of 3 features fulfilled in order for us to say this patient qualifies as a poor responder. And what are these features? So it could be advanced maternal age, so over the age of 40, a previous poor ovarian response to stimulation. In other words, if we have a poor oocyte yield in a previous cycle of less or equal to 3 oocytes, or if we have an abnormal ovarian reserve test that is proven by an abnormal antral follicle count, an abnormal AFC, or a low level of anti-Mullerian hormone of AMH. So if 2 out of the 3 are there, then we can say that this patient qualifies as a poor responder. But again, poor responders are really again a very heterogeneous population. There are different subgroups that could be older, they could be younger, we could be discussing extreme poor ovarian response. So in 2016, Poseidon criteria came along, and they had more of a clinical endpoint for the physician, and in order for us to further subgroup these patients and take it from there. So this is with respect to the poor responders. And then premature ovarian insufficiency has a very strict definition. So we're talking about premature ovarian insufficiency when there's cessation of menstruation for women under the age of 40. And this is it. And the issue with POI, with premature ovarian insufficiency, is that we need to keep reminding ourselves that we need to see this patient as a whole. So it's not just infertility; is just part of the story. There are other issues involved. The menopausal symptoms, psychoaffective changes, mood liability, vasomotor symptoms such as hot flashes and night sweats, and osteoporosis, or a higher association to develop an autoimmune disease, and so on and so forth. So we need to consider these issues for prematurely ovarian insufficient patients. And then we have the physiological processes that lead to ovarian insufficiency, and we're describing the perimenopausal and menopausal patients. So in perimenopause, we know perimenopause is the period preceding menopause, so it can last 5 to 7 years prior to menopause. And during that time, we observe a progressive reduction of ovarian function, and that manifests as menstrual cycle irregularities and mild vasomotor symptoms, and that pretty much leads to menopause, which is the final stage, and it's classified when we have at least 12 months, so 1 calendar year of amenorrhea, not having our periods, and cessation of folliculogenesis. There's nothing happening. There's no oocyte being produced. So definitely ovarian insufficiency is really difficult to manage, is really challenging, and we know that basically aging is the big enemy here. And we know that as we age, that fertility rates drop and risks actually increase. And if we're going to be proactive about it, and if we're thinking how can we actually extend our fertility and preserve our fertility, and if we're worried about an anticipated gamete exhaustion, if you like, then we can go ahead and do oocyte cryopreservation. And the results are going to be great, especially if the patient, especially if the woman is below the age of 35. But in IVF, what we're really worried about and what we're really concerned about is the golden decade of 35 to 45. These are the women that we treat in the IVF lab. So what do we do there? Well, to begin with, we used to think that we have to compensate somehow for the ovarian insufficiency that is coming up. And in the early days, we used to do that by trying to maximize ovarian response to stimulation. But thankfully, it didn't take that long, or actually it did take longer than we'd like to admit, to actually realize that this is not the right way to go, because with ovarian insufficient patients, they're not going to respond that well, irrespectively of how much of a hard conventional stimulation protocol we use. So then there was the approach of the natural cycle and the modified natural cycle and embryo banking and so on and so forth. So things have started improving, so that we were issues that pertain to how can we really target this at the core. How can we start thinking about rescuing oocyte competence and rejuvenating the ovary and really hit this at its core and where the problem lies, rather than trying to treat the symptom. And so we're discussing the novel approaches now, and this is where we are, and that is prior to actually offering a solution to the problem, which at the moment, the solution to the problem would be oocyte donation. So this is where we are right now. So what drives emergence of these novel approaches, if you like, is the patient's will, is the patient's desire to explore all alternative options in their pursuit to exhaust all possibilities, practicing their reproductive autonomy right, and that pertains to a right for a genetically linked offspring prior to continuing with oocyte donation. So this is really the driver behind everything. And now entering the novel approaches, I would like to separate them in 2 categories. So in one category, we have the novel approaches that actually their aim is to restore the jeopardized ovarian microenvironment. So we're talking about ovarian rejuvenation, if you like, or ovarian function reactivation. And in this category, we have platelet-rich plasma, PRP, that we will be discussing in a moment, and we also have stem cells. And on the other hand side, we have the novel approaches that actually focus on the oocyte, not the ovary. So their aim is to restore oocyte quality and oocyte competence. And in this scenario, we have been introduced to MRT, and we will be discussing that a bit further on too. So let us start with platelet-rich plasma, PRP, and I will be discussing the intra-ovarian infusion technique here. So what is PRP? So PRP is an autologous treatment. So the moment we hear autologous treatment, that sort of relaxes everybody. So it's an autologous treatment, and basically peripheral blood is drained, and that is later 30 to 60 mils of that, and that is later centrifuged and prepared. And in the end, we end up with a concentrated version of the patient's plasma enriched with the patient's own platelets. So this is what constitutes PRP. And so it's pretty straightforward, if you like. And what is it that this magic concoction of PRP includes? PRP consists of numerous proteins. We have cytokines and growth factors and hormones. And so it's a cocktail of growth factors such as VEGF and IGF-1 and all that. And I'm not going to go into detail with all that. But what do all these do? We want to know what all these magical factors do. And basically, these proteins serve as chemoattractants. Basically, what they do is they attract to the tissue, to the target tissue, stem cells, macrophages, neutrophils. And what all these do is they contribute to tissue regeneration. So all these factors are considered responsible for cell migration, differentiation, proliferation, activation of angiogenesis, which is what we want in an ovary that's compromised, and tissue regeneration. So all of that is there. And what is more, PRP has been proven in other disciplines. So PRP has emerged among the most innovative autologous blood products to enhance tissue healing and regeneration. And we have seen that for tendonitis, nerve injury, osteoarthritis, so various disciplines, PRP has proven its efficiency for. So it didn't take long for certain experts to start thinking, how can we turn this to our advantage? How can we use PRP in the reproductive system? And actually, the pioneers behind the development of PRP Intra-ovarian infusion are Dr. Konstantinos Pados and Dr. Konstantinos Fakenoudis, along with Dr. Nitos at Genesis Athens Clinic in Athens, Greece. So basically, they knew that all these degenerative phenomena were leading to collapse of the ovarian niche and disruption of the network. And as a result of that, the oxygen and the nutrients were just not there. So follicular growth was compromised. So all these were known. And then there were studies indicating that this condition, however, may be reversible and follicular growth could be stimulated. So this is what encouraged these experts to develop the intra-ovarian infusion of PRP treatment. And we're actually in a very good collaboration at the National and Kapodistrian University of Athens Medical School, the Department of Physiology, and we're investigating the efficiency of autologous PRP intra-ovarian infusion in regards to reactivation of the tissue. So this is what's been happening right now. So let's just say a few things about the technique. I'm sure you want to hear that. So basically, the technique is, again, relatively straightforward. It resembles a lot the oocyte retrieval technique. So the patient, principally the patient is under inhaled minimal sedation, and they're using the transvaginal ultrasound monitoring and performing multiple sites injections on the ovaries, and then that follows with infusion of the prepared PRP mixture, about 4 mils of that. So this is what pretty much constitutes the technique of PRP intra-ovarian infusion. And there are studies coming up. We're actually running in collaboration with Genesis Athens Clinic. They're running 4 randomized controlled trials. And as I will explain later, this is where the hard data and the proof is going to come from. And we're also in the process of publishing some pilot study data, which is going to be considerable. But in the meantime, there are reports and other evidence. So, for example, we have here a case report on enablement of pregnancy for a woman in premature menopause. And we did see there that 6 weeks following autologous PRP, there was a significant reduction in FSH levels and an increase of AMH levels. But so this was an indication for Dr. Panos and Dr. Fakenoudis and their team to actually go ahead further and investigate that further. And then there were other groups that followed. Palermo's group, for example, that brought further evidence along these lines with respect to poor responders, and so there is room for investigations here. And then following that, in Genesis Athens Clinic, they published 2 more case series, one on poor responder patients and one on menopausal and prematurely ovarian failure patients. And what is interesting to see here in our study is that within a 3-month interval for the poor responder patients, we saw a decrease in FSH and an increase in AMH, and the results reported natural conception at 24 weeks and an uncomplicated healthy pregnancy at 17 weeks, and so on and so forth. These are actually all out now live births because this was a while back. And then another study on menopausal and prematurely menopausal women following PRP treatment was similarly quite impressive, even though we're discussing case series right now. And like I said before, the hard data is going to come from our studies. But nonetheless, the important thing here to see is that there was menstrual cycle restoration for these patients within the first 2 months following PRP. And again, the time frame required for achieving a pregnancy was 2 to 6 months. So that is important information that we get there. But it's not just infertility that we're looking into, because apart from that, ovarian insufficiency, like I said earlier, leads to menopause-like symptoms that are jeopardizing a woman's well-being. So if you look at this pie chart from Genesis data, we see that almost 50% of the patients are actually inquiring and pursuing PRP treatment for youth and for menstrual cycle restoration. They're looking to feel better, they're looking to feel younger, they're looking to get pregnant naturally, and that sort of thing. And also on the right-hand side, you can see some data from relief rate following PRP for menopausal-like symptoms such as mood swings and hot flashes and so on and so forth. So it's not just infertility. It is more than that. It is more than that. So the conclusions on PRP is that it may restore ovarian function in these patients and lead to cycle restoration within the first 2 to 6 months. It may promote folliculogenesis. That's just what we've seen so far on this case series. It can improve the patient's hormonal profile and relief from vasomotor symptoms. But it still requires serious consideration regarding its biological efficiency, and we still need molecular data and basic research data to come in as well to validate all that. And like I said before, the RCTs are going to actually give us the final verdict on PRP. But so far, the question, I guess, is, does PRP work? Well, PRP seems that it does work, but it does not work for every patient. So our job here, and there is data indicating that the patient's profile may actually significantly affect the PRP's therapeutic efficiency. So our job here is actually find out who are the patients and what is the profile of the patients that PRP works for. So that is definitely the next step. And again, like I said before, we have 4 studies. Genesis has registered 4 studies, clinicaltrials.gov. So the data will be coming up. So that is with respect to PRP. And let us move on to another novel approach that has emerged and has been described as stem cell ovarian transplantation. So what is that? Let's go ahead and see. So we know that there are different sources of mesenchymal stem cells, and basically in the studies that we've seen, we examined the bone marrow mesenchymal stem cells. And what is it that we know about stem cells? So we know that they migrate to damaged tissues and organs and differentiate to tissue-specific cells, and they promote the healing properties, and they secrete a wide spectrum of growth factors such as chemokines and so on and so forth. And you'll see there are a lot of similarities here with regards to PRP as well. A lot of similarities, a lot of differences as well. And they exert anti-apoptotic properties and they limit tissue degeneration. So it didn't take long to start thinking, could this be it? Could it be that ovarian transplantation would restore the jeopardized ovarian microenvironment? So could this be the answer to our problems? And there are a few studies out there. I have decided to present this by the group of Antonio Pellicer and Ivy Valencia. So basically what they've done here is that they've used mobilization of bone marrow stem cells from peripheral blood. So they've done that employing G-CSF factor to mobilize the stem cells to get into the peripheral blood circulation. And then they isolate bone marrow stem cells. And the technique that they're using to expose the ovaries to stem cells is ovarian catheterism. So this is what this study describes. And similarly, So similarly, again, there are various studies out there, and there are different types of studies. So we have from case reports to pilot studies, observational prospective studies, and different patients, premature ovarian failure patients, premature ovarian, poor ovarian reserve patients, and perimenopausal women because of advanced maternal age. And we've seen in these studies that there is cycle restoration and hormonal recovery. They do report follicular growth reactivation and pregnancy via IVF or natural conception in some of them. So, what are the conclusions? The studies are out there. Some of the studies are out there, but there are conclusions, but there are also questions that emerge because we have a lot of options with stem cells. So, will it be heterologous or will it be autologous transplantation? With heterologous, it's non-invasive, but there is the risk for graft rejection. With autologous, it's invasive, but we run the risk for graft rejection. What we should really focus on is to investigate the potential use of other sources of stem cells for autologous transplantation, apart from the bone marrow mesenchymal stem cells. And safety, we know, there are notions for malignant transformation. We see that for every regenerative approach. But it is what should be determined here is what is the appropriate protocol. So the appropriate dose and the specific administration time following stem cell harvesting, we need to try and strike a balance there. And again, with regards to administration method, could be done laparoscopically, it's more invasive, could be done with intra-arterial ovarian catheterization, like we've seen earlier. It's less invasive. Are these equally efficient? We need to look into this further. But it does seem, the stem cell does seem to be a promising approach. It may effectively restore ovarian function and promote folliculogenesis according to data, and it could improve patients' hormonal profile. Again, similarly, the experimental status is retained until we have further data from RCTs and well-designed clinical trials. And until then, we need to define the appropriate protocol, appropriate dosage, and administration time, like I said earlier. So this is it with regards to the stem cell transplantation novel approach. And let us move on to the final novel approach we'll be discussing today, and that involves the improvement of the oocyte competence. So let's see what happens. So it all pretty much started, well, it started way earlier, but officially, it all pretty much started from this publication in 2017, and this was on a live birth derived from an oocyte spindle transfer to prevent mitochondrial disease. So this is the so-called three-parent baby. So what we have here, we have a case report of a female carrier of Lee syndrome. So this woman suffered a long history of multiple undiagnosed pregnancy losses and deaths of offspring as a result of this disease, and they decided to undergo IVF and reconstitute her oocytes using the technology, the state-of-the-art technology of mitochondrial spindle transfer. And as a result, there was live birth of a baby boy that is about 3 years old right now, although we don't have a lot of pediatric follow-up data. So what was the rationale behind development of the MRT for lower oocyte competence? We started thinking, or when I say we, I mean the scientific community, they started doing, so these experts started thinking, how can we use this state-of-the-art technology to improve on the oocyte? How can we do that? And let's just start thinking about mitochondria and what they are, so that we'll start delving into it and understand the rationale behind it and how logical or not logical that is. So we know that to achieve fertilization and development, huge amounts of energy are required. So where does this energy come from? It comes from mitochondria. And mitochondria actually are the energy factories of the cell, if you like. So they make everything move. And there is a proven association between mitochondrial DNA and poor oocyte quality and ovarian reserve, and that has been proven. We also know that we heavily rely on mitochondria. We heavily rely in the embryo up until day 5, heavily relies on mitochondria energy. So advancement of age corresponds to reduction of functionality number of oocyte mitochondria. So that is another thing that we know, that is another given. So the hypothesis that is formed is, okay, if mitochondria is the answer to everything, And let me just remind you here that mitochondria we inherit from our mothers, and also mitochondria actually include DNA. So this is where the heteroplasmy scenario that I will be discussing a bit further down comes in, and the fact that we are talking about the preparent baby, but we'll get that in a minute. So if we get an older oocyte mitochondria and we replace them by mitochondria from a younger oocyte, would that improve the oocyte function? Is it the answer to our prayers? Is oocyte rejuvenation a possibility? And there are various different techniques with respect to how this has been done. There are issues on the techniques. There are technical hurdles on these techniques at the moment. It could be heterologous, it could be autologous, we could be using it, we could be employing the germinal vesicle, the spindle, or it could be the prenuclear transfer. But in order for you to have an idea of what we're discussing, I have introduced this slide and we will be explaining the prenuclear transfer. So this is how it works in a nutshell. So you have your patient couple and you have the patient oocyte that features the diseased mitochondria, if you like, the compromised mitochondria. And then we have the donor oocyte. So this is where the third person comes in. So we have the donor oocyte. So what we do is we enucleate, we remove the nuclear DNA from the donor oocyte and also from the patient's oocyte. And what we then do is we move the nuclear DNA from the patient oocyte into the cytoplasm of the donor oocyte. As a result, we end up with a donor oocyte that is left with nuclear DNA from the patient and DNA from the donor. So this is where heteroplasmy comes in, and we're discussing the various DNAs because this oocyte will further be subjected to fertilization and hopefully employed to achieve a pregnancy. So this is how it happens. On the other hand, there is the Labarta study has been discussing autologous mitochondrial replacement therapy. So in this scenario, we're actually acquiring our mitochondria from our own body. So laparoscopy for ovarian biopsy, and then we sample the ovarian cortex. And of course, all this is much more complicated, but we're simplifying now for all these purposes. So oocyte precursor cells are identified and then isolated. And basically, we use this mitochondria, we inject this mitochondria into the oocyte, and this is how this works. Again, in a nutshell and oversimplified. So again, there are various studies out there. The study by Okfei actually showed encouraging results for mitochondrial replacement therapy for patients of low oocyte quality. So when they compared the previous IVF cycles and their post-IVF cycles, post-MRT, did show better results. Then we got the very interesting study by Pellicer, the AUGMENT study, where they used autologous mitochondrial transfer, and it showed that it does not seem to improve prognosis for this population. And the study was actually discontinued. This was a very, very big study. So that was very, very interesting and important data that we should be considering. And it seems that the presence of more than one source of mitochondrial DNA in the resulting oocyte is experimental, and it requires a lot of further testing that is mandated by the FDA. And this is why things have been pulled to a stop at the moment. And the ICT of Labarta et al. Was proof that the AUGMENT was not efficient. But even using the technique in order to avoid transmission of a mitochondrial disease requires thorough safety assessment. It requires further and further testing before we proceed to clinical implementation in humans. What is more, there are ethical concerns related to this baby's health and related to transmission of mitochondrial diseases that may be stemming from the donor. How do we know what's happening? There's DNA in there. So, excuse me. So basically, the UK actually allows mitochondrial replacement therapy to happen, but only for on the grounds of avoiding mitochondrial diseases in the offspring. So this is where we are right now. And in fact, in 2019, ESHRE publicized a statement with respect to MRT for the use of infertility, saying that extreme caution should be recommended for the use of spindle transfer in humans oocytes as a clinical application for addressing infertility problems. Because addressing infertility problems is a different matter than avoiding mitochondrial disease. So these are two, maybe the same technique, but it's completely different application, and the grounds for application is different. So we need to weigh in the pros and cons. And in lack of solid evidence providing that the spindle transfer is that is working and that there are higher live birth rates, then until that time comes, then it should be seen as vague and unproven. And this is what ESHRE has publicized on this statement. So with respect to MRT, there's lack of robust or even adequate data, and we require long-term follow-up is required. But long-term follow-up, to be fair, is required on all novel approaches. So we need to be careful. Again, RCT is a requirement. It's the only way for something to lift off the experimental brand, if you like, and say this is clinical routine practice and you can apply horizontally to everybody. So this is what we need to make it work. And so this is where we are, and the question is, this is where we are. Where are we headed? There's talk of artificial gametes. That might be the future. Are we there? Where can we use cells to turn them into oocytes and sperm and proceed to fertilization that way? It sounds a lot like scientific fiction, but we need to think that some of the things that we're doing now used to sound like science fiction 20 years ago, or even 10 years ago, or even 5 years ago. So we need to be very careful with respect to where we're headed, and we need to consider the drivers. What is it that drives these novel approaches? Public opinion, addressing the extreme cases in art that don't really have any other alternative, addressing graft rejection. But we need to see where we are, and we need to acknowledge the bioethical debate and experimental stage that some of these techniques are facing, and how does that progress. And there are also safety concerns. We need proof of efficacy. And further to that, there is lack of legislative framework. So there are still a lot of limitations, but we need to make room for some bioethical consideration with regards to some of these techniques. And we need to we need to accept that we need to move forward with proper research methodology. It's the only way to make patients feel safe and provide RCT data prior to any notion for horizontal application for any of these techniques. So I would like to thank my wonderful team for being with me in this beautiful journey and making everything inspiring every day. And I'm very thankful for that. And also I would like to thank you for your attention. So this is it from me, Caroline. I'm going to give it back to you, and then I guess we can start with
Perfect.
The questions, if there are any.
Thank you so much for that very impressive, interesting presentation. Lots of details, definitely useful ones. And yes, it is time for the questions. There are some questions ready, of course. And of course, let me just start with them. The only thing is that right now, we need to do it a bit differently today, okay? Simply because our Q&A mode, unfortunately, we're having some technical issues, so it's just simply not possible for me to show them on the screen. But do not worry, they are visible on the chat section, and Mara, we are able to do it, right? You will be able to see the questions in the chat section. I will read them out, okay?
Yeah.
All right. Just one more thing. I will need to disappear for like 1 second, because right now I believe you cannot see the chat section, right?
I can see some of the questions.
Okay, that's good. Just give me a second. I will be right back with you.
Okay.
About this, I just needed to refresh to make sure that all is done. And now we can go ahead with your questions. Apologies, this is out of my hands. We are simply not able to fix this right now. However, I believe we can manage, right?
Yes, of course, we'll do our best. Don't worry.
Okay, perfect.
So how do you want to do this? Are you?
I will read out the first question you can see, okay, and we will go on like that. So the first one is from Angela. Unfortunately, we have gone through 10 IVF failures, 8 with my own and 2 with an egg donor, always resulting in miscarriages. I'm in my 50s and now in menopause. I've searched doing a nuclear and spindle transfer mitochondrial replacement, but my AMH is 0, so looks like I'm not a good candidate. Do you suggest I try to do a cycle restoration treatment with stem cells to try to do another cycle with the mitochondria replacement with an egg donor? I will be using a surrogate this time.
Wow. Okay. Hi, Angela. So, like I said earlier, let me just preface my response by saying that I'm a clinical embryologist and a researcher, and so probably you would need a physician to try and answer this very complicated reproductive history that I can see um, you have been facing. So I cannot really suggest something at this point in time. It doesn't, I would suggest that it is a good idea that you're looking into what happens all this time that you didn't get pregnant, and also with respect to the uterine environment. So I don't know how much you have researched that other than your own oocytes and whether they were competent or not. Apparently they weren't all that much, but I don't have a lot of data on your IVF cycles, and also I'm guessing all these efforts were done throughout a couple of years, so things can be changing after a couple of years. I can see you've had two attempts with an oocyte donor. Okay, and I'm sure you have done PGD, but again you've had your oocyte donor. It's really difficult to actually answer this. I would suggest that you need to make sure that you trust your doctor and you have a very good relationship with your doctor before you move any further. I don't know about stem cells though. I would not be very much, it's definitely not easy to answer this question, but I'm not too sure about stem cells. If we're talking about restoration, maybe you want to give PRP a go, but I'm really not the right person to actually be suggesting any of that. I would definitely suggest though to research further what's been happening on the uterine front. So that's as far as I can go with this question.
Okay, thank you still, of course, for your question as well as your
Of
answer
course.
to this. Perfect. Thank you so much. Okay, next question is right here. What are the disadvantages of PRP? Can it cause cancer later in life?
Okay. Right. So the experience basically again, I'm not the right person to be discussing this, but the experience that I have from PRP is from all the work we've been doing with Genesis Athens Clinic. So in my eyes, these are the experts with regards to PRP. Disadvantages. One of the disadvantages would be PRP not working. It doesn't look in the studies that we've done so far. It doesn't look that there are any side effects that actually, rise any red flags. We don't have any long-term follow-up data because it's so novel. You cannot have long-term follow-up data. But it doesn't look like there is anything to raise any suspicion. With regards to can it cause cancer later in life, again, every time there is the regenerative medicine being mentioned, cancer and malignancies are being stirred up, and notions of that come up. But certainly, the work that we've done so far, and there are a lot of pregnancies that we've had from PRP, that Genesis Athens Clinic had from PRP, that we haven't seen anything that has been troubling so far, other than the fact that it's not working for everybody, like I said before, and our job next is to find out the patient that this is working for. So this is as far as it goes with respect to this question.
All right, perfect. Again, thank you so much for that explanation. Next question is, can you use PRP or MRT to treat autoimmune diseases like hypothyroidism?
Okay, I am completely out of my expertise with respect to autoimmune diseases, but we've seen PRP and we know that it has regenerative qualities, but I wouldn't go so far as to discuss anything with regards to autoimmune diseases or hypothyroidism. So
That's perfectly okay, of course, no problem. Thank you so much again, still. All right, and sorry, there's another question right here. Which of the mentioned treatment options would you suggest as the best option for a 46-year-old single perimenopausal woman who wants to have a genetically linked child?
okay, I see. So, like I explained in the talk, I'll take the opposite direction. With regards to MRT, we'll still have a very, very long way to go. And recommendations for MESRA is no, not for infertility treatment. So that would be a no for me. And between then, that leaves us between PRP and stem cells transplantation. Like I said, with stem cells, there are a lot of questions with regards to which protocol is more optimal. And there are clinicaltrials.gov that have been registered with regards to ICPs and so on and so forth. But I would think that at the moment, the data that I've seen from PRP is interesting. Again, the issue is that there are no guarantees. This is what's happening with novel approaches. If there was a novel approach that would give us a guarantee of that it would work, then my talk would not be 30 minutes. My talk would be 3 minutes. But we're not there yet. We're doing a lot of work on PRP, and we have seen it working on some patients. So this is where I would probably go to.
Okay, perfect. Thank you once again for that. And yes, we definitely need to wait for more research.
And again, just on the grounds of the fact that it's less invasive. So yes, absolutely, but it's also less invasive than stem cells. Stem cells, especially with regards to autologous stem cells, way more invasive. PRP is a really straightforward procedure to actually obtain and prepare. So that gives it an edge. It's more, if you like, user-friendly, if you like. So.
Okay, thank you. Next question is right here. Is the
okay, we can move to the next one.
Yep, sure, sorry. So is the augment technique still being done anywhere in the world? I read about a company that was doing it and trailing, in Japan, but has it been discontinued now? Anything you could add on that? It's the question from Kay.
Yes, the augment technique. Augment technique. I've not, I cannot say that I know what happens all around the world. I'm sorry. Personally, I'm not aware whether augment technique is being done somewhere right now at this point in time. But I do know that the large study by Labarda that started was very hopeful, and the same group discontinued the study because it didn't look like it conveyed any promising results. So I cannot answer that. I would suggest just looking into clinicaltrials.gov and see if there's anything registered. But I would say, the fact that the group from EV Valencia discontinued it, it's an indication for me with regards to augment and its efficiency. So that's as far as I would go with regards to this question.
All right. Excellent. Thank you so much once again for that. And next question is right here. In my first ovarian stimulation, 37, AMH was 0.47. The outcome was 7X, one best quality embryo, 6AA. We proceed with implantation, but no pregnancy. In my second ovarian stimulation, 38, AMH was 1.07. The outcome was 6X, and no embryo reached the blastocyst stage. I will try once more with my own eggs. What protocol do you suggest? Mild or high doses? What preparation? I should do 3 months prior to stimulation. Is there something that can do to improve egg quality?
Okay, I see. So again, with respect to Olga, like I said, I am not a physician, so it's probably not the best idea that I provide advice with regards to treatment as such. We definitely suggest to try it again. We do not know at the moment. Have you been trying anything else? We don't know at the moment if it is an egg thing, because it looks like, despite your AMH, you got 7X and you got a very good blastocyst in your first attempt, so that looks good. We don't know what happens when something doesn't work, when we don't get a positive biochem, we don't get a positive HCG test. We don't know what has gone wrong. It could be something uterine, it could be the embryo, it could be something combinatorial factor, it could be something else, it could be like an overall thing. So it's not so easy as to point your finger to something and say, this is what has been wrong. So your first cycle, from an IVF lab perspective, looked like it went really well. And then in your second cycle, when you were 38, you had 6 oocytes, which is fine. That's a perfectly compatible number of perfectly compatible oocyte yield for your age and especially for your AMH. But it didn't reach blastocyst stage. Again, this is not an indication that an embryo not reaching blastocyst stage has to do with various reasons. I do not have a lot of data on your cycle with respect to how did those embryos actually develop in the IVF lab. Not reaching the blastocyst stage is one piece of information, but it doesn't say it all. So I would definitely suggest to try again. I mean, your oocyte yield is good, and the fact that you've had a blastocyst embryo in your first attempt is definitely hopeful. With regards to the protocols, again, because of your age, I would probably suggest something, a flare up or a high stimulation protocol, but nothing too high. But again, I would suggest that you need to trust your physician and the doctor that's treating you at the moment, feel that you're in safe hands, and then you move ahead with the protocol that they suggest. With
Perfect.
regards to improving oocyte quality and thermal treatments or adjuvants, then there are some supplements that you could perhaps use that might help the oocyte metabolism. But that's as far as I would go with regards to the question.
Okay, thank you
Mm-hmm,
once again for
mm-hmm,
your help with this.
mm-hmm.
And the next question is here. Which countries currently offer these treatments? So PRP, stem cells, MRT, any others besides Greece and Spain? Do you know any other countries?
Mm-hmm. Okay. So there's the States that also offers PRP. So if you're closer to the States, then that might be of help. Um, yes, and I would suggest if you're looking at alternatives, why don't you just go to clinicaltrials.gov or any other registrations and look for registration, look for studies that are actually being run on PRPs or stem cells. And that will help you, that will guide you with regards to this geographical position and where these groups are being based. Um,
Okay, understood. Thank you so
so
much once again.
clinicaltrials.gov, and you can see the trials there, and you can get information.
Perfect. Thank you. Next question is right here as well. I am 40 and single. I've had a tube removed and had three funded rounds of IVF. I am a poor responder, had 2, 3, and 5x retrieve, fertilized with ICSI, had short, long, and mild protocols, AMH 8.28 and AFC 8. What would you recommend for me next?
Again, I will have to disappoint you, Ellen, because I don't. I do have an opinion on this, but I certainly think this is not the right position for me to be offering advice of such kind. Just because I'm not a physician, I'm not a fertility specialist on that end. I'm a clinical embryologist and a researcher. So I think it would be, like I said before, the ideal situation is to feel that you can trust your doctor and that you've made a very good decision with respect to your doctor and just trust the protocol that they're prescribing.
Okay, of course. Thank you so much again for that. And that's
But what
perfectly
I have to say with
understandable.
regards to Helen is that she's 14, she's had 3 and 5 eggs retrieved, so that is, there's hope with that. You should definitely try again. And again, your AMH, I don't know, your androfolk account is okay. Um, yes, trust your doctor, make that decision, and just go with what your doctor says.
Okay, perfect. Thank you so much. And
Mm-hmm,
now
mm-hmm.
there's another question, okay, with some details. So I am 40, AMH 0.2, FSH 23, and AFC was 7 in 2018. The last recent scan AFC was 0. Which one of those procedures do you think I can benefit from?
Yeah. Okay. So that is basically similarly to before. I would have to say again, I do want to stress again that I am not a physician, but with respect to the data that I have from this question, and if I had to choose out of the three, I would go for PRP. Because, and of course, I would say that I'm inclined to say that because I do a lot of work on PRP. But this is what I've seen. This is what I know. PRP is rather straightforward to prepare. It's non-invasive. It's minimally invasive with respect to the procedure. So, in regards to efficiency, again, we need to see the hard data. We know that it is working. It seems that it's working, but it's not working for everybody. But then the same stands for stem cells. I wouldn't, MRT, like I said, the ASHRAE standpoint is very precise. It's very specific. It should not be viewed as an alternative right now. MRT, as long for the reasons that have been stated, according to ASHRAE. But between PRP and stem cells, I would be more inclined to do PRP.
Okay, excellent. Thank you for that explanation as well. And
But
so,
I would like to stress at this point, like I did at the end of my talk, that we need to be novel approaches require some patience. This is why we call them novel approaches. We need to allow for some time to see the data. We need to see the data so that we can actually answer these questions with conviction, and rather than I would be more inclined to do this or to do that. With what we have in our hands, yes, this is what I would say, but we need more data, and we have to look at research groups that actually run this kind of data and find out more from them.
okay, understood.
So
Perfect.
it's, PRP, for example, PRP is a procedure that can be done, but the centers that actually offer it, where do they rely their practice? We need to be careful. That's all I'm saying. They're all novel approaches. We need to allow for time.
Okay. Thank you again for that. And for now, at least, this looks like our last question, but I just want to remind everyone that if you have any questions left, go ahead and type them in right now so that Mara can answer that for you. And the question is, so are there any contraindication for PRP treatment?
Mm-hmm. Again, I would suggest to discuss this with a physician. There are some contraindications with regards to PRP treatment. If there is a blood a disorder of the blood system, for example, that would not be a very good indication. And there are other things as well, but it's not a good idea for me to provide advice on that matter. I think that you should seek advice from the experts on PRP. The ones that actually practice it clinically. Because like I said before, I'm on the research end, so I can give you data with regards to where we are now and what it looks like. But yes.
Of course. Thank you again. Well, someone
Mm-hmm.
is typing, so I definitely want to make sure that we have answered all the questions. So let's give it a minute and wait to see whether it's another question. If not, we will be slowly finishing, but I just definitely want to make sure that you have asked all of your questions. So go ahead and do it now. And in the meantime, we have another question here. So how is premature ovarian insufficiency diagnosed?
Okay. So when you have a compromised ovarian function below the age of 40 and there is a cessation of menstrual cycles, then that means that this is premature ovarian insufficiency. We do have tools to have an idea of whether that is coming up, and levels of FSH, LH, and anti-Mullerian hormone, along with antral follicle count, is definitely, and also the ultrasound, the impression that we have, from the ovaries, the ultrasound finding from the ovaries, that is also something to think about. We can that can give us an idea of whether that is coming up, and then there are tests to be done just to make sure.
Okay, thank you for that as well. And in the meantime,
Mm-hmm.
if you could repeat, because you have mentioned that there is a
Oh yeah,
patients can check.
it's the clinicaltrial.gov. So
Okay,
clinicaltrial.gov is a registry, and when a center research team actually performs clinical trials, prospective clinical trials, randomized control trials, and so on and so forth, they're actually registering them. They should be registering them. Well, everybody registers, but they should be registering them. And this is where you can get information with regards to what are the centers that are actually performing PRP treatment or that are running randomized control trials. Thank you,
So
Radka.
perfect, thank you. And so
You're welcome.
clinicaltrials.gov, right? I believe that you
Mm-hmm.
have said that. Yeah,
Yeah, yeah, that's correct.
okay. I think that's the
Okay.
website. Just
Yeah,
in
that's
case,
it.
so you can just use it and double check it where exactly you can also have that done possibly. And well, it looks like we will be finished for tonight, so I would like to thank everyone for joining our IVF webinar tonight. So once again, because I know you are joining our events quite frequently, so huge thanks to you. And well, Dr. Mara, it's definitely interesting. Those topics are, well, we will definitely have more of those simply because it's something that is still not research till the end, so we still need to wait. But
Absolutely. We need to find
that's
out what is next. We need to find out the next
exactly,
season, what's happening in this.
exactly. But
So it's been a pleasure. Thank you very
exactly.
much for
Thank
having
you
me.
so
I hope
much.
I have been helpful. Thank
I
you.
am sure you have been helpful, because as you can see, there are comments right here. So you can see some thank yous. Thank you very much.
Thank you.
Many
Take
thanks
care.
covering this interesting subject. Amazing presentation, giving a little hope to us. So thank you. Excellent talk. So there's
Very
plenty
happy,
of those.
Caroline. Very happy. Take care of yourself
Okay.
and good night to
And
everybody.
well, I would like to let everyone know that this has been recorded, so you will have a chance to re-watch it within the next few days. It will be uploaded on our website, myivfanswers.com. But if you subscribe to our YouTube channel, you will be able to see when the new video is uploaded. So go ahead and do it. I definitely encourage you to do it. And of course, you can also register to our next events. Those are happening still. We are having 2 events every single day, so we will be back here tomorrow as well. Again, Dr. Mara, thank you so much for joining us,
What
and
a
have a
pleasure. Thank you,
lovely
Caroline.
evening. I know it's
Thank
quite
you to
late
everybody for being here with us.
for you. Thank you
We're
again.
moving forward and stronger together, but moving forward.
Exactly. So
Okay.
fingers crossed, right? Thank you and bye.
Take care. Bye. Bye, everybody.